Hi, I'm Dr. Steve Stevens. I'm a cardiology fellow at the Cedars-Sinai Heart Institute, and this is a study actually done during my residency at the University of California, San Francisco, with mentors Nelson Schiller and Mary Hooley. This is from the Heart and Soul database, which is 1,024 patients with stable coronary disease that were seen in ambulatory clinics in the San Francisco Bay Area. And what we look to find is in patients with intermediate QRS prolongation. So this is patients with a QRS of 100 to 120 milliseconds. If that predicted bad things, particularly heart failure, as these are patients without known heart failure. And little is known about QRS duration when it's less than 120. We certainly know that over 120, left and right bundle branch block predicts bad outcomes. It's been shown in Framingham and so forth. But for this, we don't really know what to do with this information when we see a QRS of 111 milliseconds or so. So the outcome we found was that it strongly predicts heart failure. Looking at the gross numbers, the 29% of patients with intermediate QRS duration develop heart failure, being quantified as heart failure exacerbation requiring hospitalization. 29% of them had this within 5 years, where it was only 12% in patients with narrow QRS. Now, this is a higher risk population because they all have known stable coronary disease, so they are prone to heart failure, but 29% seemed excessive. And then when we looked at other markers such as echo findings in BNP, it actually adjusted and was still significant, the hazard ratio being 2.8 with just adjustment for age, and then after adjustment it was 1.9 with the p-value of 0.03. And then looking at the echo markers, it correlates with LV mass and low ejection fraction, less than 50%. It's strongly correlated with, but still independently predicts when those are put in a model. And those echo findings, we think is that this is showing overall that there's scar and hypertrophy in the left ventricle, and that's what's causing the QRS prolongation and making the patients higher risk for heart failure exacerbation. And there's also a trend towards mortality, but it's not underpowered to find that. And I would imagine there's a risk of sudden death, but again, it's underpowered to find that. When you see a 12 lead EKG with an intermediate QRS duration, that's not a benign finding, and that people should take that seriously. This is a high-risk patient population that's going to be at risk for bad outcomes in the future, and they should be aggressively medically managed to prevent those events.